Hello there. Today we have a special guest here with us. This is Danny Wainwright. Danny has worked with me for several semesters in our simulation lab, and we has a lot of knowledge and wisdom to share with us in regards to just nursing in general. Danny, why don't you give us a little background of your work experience in nursing?
All right, I started off as a paramedic approximately 30 years ago. I've been in the Kankakee area at Riverside Hospital for approximately 26 years now. I started off with their helicopter program when they had one, and I've kind of bounced around between the emergency department, the coronary care unit, at short stint in administration, and then currently I'm working on the weekend program in the emergency room at Riverside, and then working here in the VLC during the week.
Great.
I'm also the hazmat coordinator for Riverside Hospital.
Absolutely. So today we're going to talk to you guys a little bit about disasters and traumas and trauma centers. So first we're going to start with trauma centers, and this will be video 1 of 3. So Danny, why don't you open up the conversation here?
All right, first we're going to talk about the trauma center designation in the state of Illinois. The state of Illinois is set up as a 3-tiered system of trauma designation. Level 1 trauma center would be a big teaching hospital like Cook County or Loyola, or Christ Hospital, which happens to be our pod hospital for Region 7. The pod hospital has a little bit of extra responsibilities in cases of disaster and stuff, and keeping track of who's on bypass and with patient flow. And making sure everybody kind of meets state standards to keep their designations up. Like I said, the level 1 trauma centers, they need to be able to have a patient into surgery within 30 minutes of the time they arrive at the hospital. That means they pretty much have to have a surgeon on standby 24 hours a day. And in order to do that, what they do is there's the large teaching centers where they have residents and fellows who have privileges for the surgical rooms so that they can take patients straight in. Then you bump down to a level 2 designation, which would be what both St. Mary's and Riverside Hospital here in Kankakee are. And in order to do that, the surgeons have to be able to respond to the hospital within 30 minutes in order to take the patient. So they don't have to be right there, but they have to be able to come in rather quickly. The crews have to be in, and then they have to be able to take the patients in. There's also different levels of training that the nurses have to do, such as trauma nurse specialists. The hospital is required to have a trauma nurse specialist on duty 24 hours a day. And then there's the pod hospital in the state will come through and make sure that all our charting is where it needs to be. We have locally we have trauma coordinators who help do our chart reviews and help us remember what kind of things that we need to chart to keep up on that. Then the third level of designation would be kind of like an Iroquois Memorial or in Watseka or a Gibson City Hospital, where they don't have quite the requirements, but they can certainly take a patient and get them stabilized, and then, if needed, move them to a higher level of care. Matter of fact, one of my good friends was in a farming accident. He had gotten burned real bad with anhydrous ammonia, and it's important that everybody keeps communicating. In his case, it was faster for his dad to drive him to the local hospital down. It was when Clifton had a hospital years ago, which was just a small 2-bed hospital. But he kind of doused him with water. He threw him in the back of the truck, called the Clifton Hospital at the time, which was a level 3, let him know that he was coming, and literally 2 minutes after he pulled into their parking lot with the pickup truck, Loyola's helicopter was landing ready to take him to a burn center up in Chicago, up to Loyola. So the communication is real important when you're trying to decide where to take patients to the hospitals. It doesn't go strictly by level. I mean, in an ideal world, if you had a level 1 patient, which I should talk about a little bit here in a minute, you should take them to a level 1 as long as it's a reasonable, transport time. But when you get into extended transport times, then you have to do what's right by the patient and take them to the most available hospital. A level 1 patient, for trauma, there's 2 levels of what we call trauma patients that we call or 3 levels. I'm sorry. A trauma patient that's a level 1 would be somebody with a sustained hypovolemia or sustained low blood pressure. It could also be a penetrating injury to the head, neck, or torso, or any type of life or limb threat. A level 2 patient is really, it's not that their vital signs are bad, but trauma is kind of a disease where you have to look for the injury. It doesn't always stick right out. Mm-hmm. So we know that if somebody fell from greater than 20 feet, if it's an adult, or 3 times the height in children, or if there's a 1-foot intrusion into a passenger compartment in a car, or a death in the same vehicle, those are the type of people we're looking at to be level 2 trauma patients, because they really have the potential to have bad injuries. So you have to take them more seriously. You have to really look to make sure that they are okay before you just write them off. And then the level 3 would be more the type of uncomplicated patients that you're planning to discharge that don't need any specialty services.
With this being said, too, with all your trauma patients that come in, you're constantly reassessing them and continuing to document on them, because their trauma score and their level of trauma needs can change, from 15 minutes after arrival to even 2 hours after arrival. So.
Right. So it's optimal that when you get a good report from the paramedics coming in, you know that you're bringing them into the right facility or the closest available facility that can do the best for the patient. It's best if you can call it from the field, get your things lined up. There's actually extra reimbursement from the government for calling a patient, leveling the patient from the field, because they want to encourage that type of communication. Then you have to follow your patient. At any time, your patient's condition can change, and they can move up or down the level scale. So you could have a patient who came in, was level 2, they become unstable, they get hypotensive, and then you can upgrade the classification to a level 1.
Absolutely. One thing we really didn't talk about too is when you're transferring your patients. Say we have a really bad accident, and I had a 17-year-old girl actually. They were driving on the country roads, and there were 3 sisters in the car. One got killed immediately at the scene. She was ejected from the car. Another one was sent to Riverside for brain surgery because she had a bleed. And then the girl that came to me actually had an open wound to her head with her brains partially coming out of her head, which is a little disturbing. However, you have to be prepared for whatever comes at you. But because of this, she was a level 1 trauma, and we were going to have to transfer her at St. Mary's. We don't have the resources to care for any kind of neurological surgical procedures, nor do we have like burn unit or anything like that. If we had a neuro patient, we could transfer to St. Mary or Riverside, or we can ship them up north, to the several options of the hospitals up in Chicago area. But one thing I think I really wanted to point out with that is that your patient, can be stable at one point and then isn't stable at another time. So you have to really consider the timing in order to get your patients to the proper care levels, but you can't get them transfer them an unstable patient, at the time. So you need to get them stabilized to some extent where then you can get them on airlift, for example, and then they can take over from there.
Right, and it's real important to keep communication with the hospital, let them know what your patients are and what's going on, because there could be unforeseen things, and sometimes the hospitals have to go down on bypass because either they're too full or they have some equipment malfunction. So it's not uncommon for a CAT scan to need routine maintenance or have a little bit of a power surge and have a glitch. So the hospitals can put themselves on bypass and say, well, you know what? The best thing for the patient is to take it to another facility, because right now our CAT scan machine is down, for instance. So we're going to have you bypass this, our hospital, go to the other ones because their CAT scan is up right now. Mm-hmm. Or if the hospitals are being overwhelmed, when you're kind of in the bigger cities, the hospitals play more of a role in keeping track of who's got how many patients with, and if somebody's going to go on bypass, or kind of help the ambulances decide where to take their patients, depending on what the different volumes are.
We did mention about, with St. Mary's and Riverside being so close, just across the river from each other, if St. Mary's were to go on bypass because they're overloaded, but now Riverside's overloaded too and they call a bypass, then we're pretty much, neither of us are on bypass at that point, because we're both extended our resources, so we have to take the patients that come to us, in that area. What else do we have for them today? Let's talk about ESI categories.
Yeah, we can talk about the ESI triage levels. We talked about the 3 levels of trauma patients that we can have, but there's also when the patients normally come into the emergency room, we categorize our patients by the ESI levels. I believe at both St. Mary's and Riverside Hospital. There's also a Canadian level system that isn't really too far different, but the ESI level is a 5-level triage system to help categorize based on the patient's needs and acuity. So a level 1 patient would be somebody who's critical, somebody who's about ready to code or is coding, somebody that everybody has to kind of hit all hands on deck in the next 5 minutes in order to save their life. Then it goes to a level 2 patient, which would be somebody that needs immediate intervention, to keep them from having the risk of death or loss of limb. Somebody like an acute MI, a STEMI or something like that would be a level 2 patient. A level 3 patient is somebody who can still be fairly sick, but just you have a little bit more time. Somebody who comes in with, like belly pain or vomiting, you're still going to use quite a few resources for them. You're still going to do a big workup. They still need some care, but there's really not that immediate threat to it. And then a level 4 person would be somebody who just needed 1 or 2 simple things, like maybe a pain shot or an X-ray, and then they would be probably discharged. And a level 5 would be somebody who was just a real simple, quick in and out, like a suture removal.
Absolutely. Yeah, and as a triage nurse, then you're considering these levels when your patients come in, and you're trying to think about how many resources is this patient going to use to help assist you in giving them a number.